Hi, everyone. My name is Daniel Luca, and I'm a movement disorders neurologist at Washington University in St. Louis. And today I'll be discussing the diagnostic criteria for MSA, specifically the Movement Disorder Society criteria for multiple system atrophy. I'll be discussing how this criteria compares with the older criteria. And I just wanted to start with some disclosures that I was not involved in the development of this criteria. And otherwise, I don't have any specific disclosures for this talk. So I'll try to summarize the diagnostic features of both MSA criteria, the older one from 2008 and this newer Movement Disorder Society criteria. I'll highlight the key differences between the criteria as well and how they compare. So just to begin with, we know that MSA is a progressive neurodegenerative disorder. It's a rare condition, but for the patients that it affects, it has an enormous impact. The prevalence has been estimated at about 3 to 5 cases per 100,000 in the US. And as we know, a lot of different symptoms with MSA, including neurological symptoms like Parkinsonism with cerebellar features, but also sleep disorder, mood symptoms, autonomic dysfunction, and so on. I'm not going to be discussing a lot of the symptoms of MSA, but as we go through the diagnostic criteria, this should become more clear, especially for the patients and family members out there. I just want to say that we had great presentations in the past about this diagnostic criteria. So Dr. Lang, about 2 years ago or 3 years ago, gave this very great lecture about the diagnostic criteria for MSA. And at the time, they were developing the diagnostic criteria. And subsequently, Dr. Meisner discussed some of the ongoing issues with the criteria and how the Movement Disorder Society criteria was developed. So just some great resources out there from this really well-established neurologists and MSA experts discussing sort of a similar topic that I'll be discussing today. So we do have, prior to the Movement Disorder Society criteria, the 2008 MSA criteria, there were some issues with this criteria, specifically accuracy. Many patients were missed, especially in the early stages when the symptoms were more subtle. It was they had a very low sensitivity for early stages of the disease. So that meant that many patients would be undiagnosed for years, which would not only impact patients' quality of life, treatment, prognosis, but also clinical research and enrollment in clinical trials. So in short, we had a system that worked late in the disease, but not early. And that's exactly when we want to intervene for patients with multiple system atrophy. So what changed and why it changed? We discussed some of the why and how exactly it changed. The new MDS criteria had the goal of improving the diagnostic accuracy in clinical practice, so trying to capture this at an early stage. The idea was that it would not only improve quality of life and care and having an answer for these patients earlier on, but also improving the enrollment in clinical trials. Plus, it would facilitate research with the validation of new diagnostic biomarkers. So the Movement Disorder Society MSA study group approached this by first performing a literature review, and according to their paper, they then performed sort of systematic steps, including an open survey and a consensus conference. And this was chaired by Dr. Wendig and Dr. Kaufman. And as I mentioned before, the motivation was not just clinically, but also research-driven, that the attempt was to move toward earlier recognition and intervention. So this was later on published in the Movement Disorders Society official journal, the Movement Disorders Journal. And I'm going to present a brief comparison. The old criteria had these 3 levels of diagnosis, neuropathologically established, probable, and possible MSA. And the new system has 4 different levels. The neuropathological or neuropathologically established MSA remains the same, but now we had clinically established MSA, clinically probable MSA, and possible prodromal MSA. And you notice that the new system tries to remove some ambiguity and clarifies the thresholds. And importantly, it also tries to integrate more imaging. And this is a table that has been adapted for some papers, but a comparison of the 2 criteria in a quick picture, the 4 different levels in the new criteria. We didn't have a lot of tools to help us with early diagnosis in the 2008 criteria, and now in the 2022 criteria, the MDS criteria had the definition of prodromal MSA. The 2008 criteria required autonomic features, and the 2022 criteria has some more simple measurements that can assist us with autonomic function that can be used in clinical settings. And it also changed some of the orthostatic hypotension definition. And the imaging is now more integral to the diagnostic criteria. This is an adapted table from this very nice paper published by Go et al. In 2023. So to summarize one by one, the clinically established criteria requires at least 1 of autonomic dysfunction, including unexplained urinary voiding difficulties, unexplained urinary incontinence, or neurogenic orthostatic hypotension, plus at least 1 of those, either poorly responsive levodopa Parkinsonism or cerebellar syndrome, including gait or limb ataxia, cerebellar dysarthria, or oculomotor features. And you do need supportive clinical features and MRI supportive of MSA. With the clinically probable, you do still need at least 2 of autonomic dysfunction or Parkinsonism or cerebellar syndrome. And the imaging is not required, and you just need 1 supportive clinical features, which I'll explain in more details soon. And for the new level of prodromal MSA, you need the non-motor criteria, which is the REM sleep behavior disorder, on a sleep study, neurogenic orthostatic hypotension, and urogenital failure, including erectile dysfunction in males under the age of 60, unexplained urinary voiding difficulties, and unexplained urinary incontinence, plus subtle Parkinsonism or subtle cerebellar signs, and no imaging required for that. And among all of those, it needs to be a sporadic and progressive condition with adult onset and with no exclusion criteria, which I'll explain in more details later as well. The supportive features that I was talking about from the previous table includes rapid progression within 3 years, or moderate to severe posture instability in the same time frame, and severe speech impairment or severe trouble swallowing. Also, craniocervical dystonia induced by levodopa, unexplained Babinski sign, jerky tremor, postural deformities, and supportive non-motor features, including stridor, cold discolored feet, and erectile dysfunction or pathological laughter and crying. And I just have some examples here of how this looks like in clinical practice. That's some of the postural abnormalities that we're talking about in MSA, including Pisa syndrome, and in this patient, it's more like a postural, stooped posture, not clearly the Pisa syndrome. In the images B, you see more the facial dystonia, and I see the classic enterocollis, as seen in some patients with MSA. We are going to discuss the imaging findings soon, including the hot cross bun sign, but also the contractures that I was discussing as a supportive postural deformity. We have the codes or discolored hands and feet. Some of the facial dystonia, like we can see in this video. So you can see there's prominent facial dystonia, and at some point there was also dysphonia. Here's how a stridor would sound like. And here's uh, the jerky the jerky tremor that we mentioned is polymini myoclonus or mini polymyoclonus. And when we're talking about some of the imaging findings, I think most people are aware of those. They haven't changed much, but you need atrophy of the putamen, metacerebellar peduncle or pons for MSA P and C. And for MSA C, you should also have or can have atrophy of the cerebellum with increased diffusivity of the putamen or metacerebellar peduncle. And it's inverted here. It should be MSA C on the left. And you can have decreased signal on RF sensitive sequences, including putamen or RIN, and tissue hyperintensity, including hot cross bund sign. And that's how it looks like. You have pontine atrophy, metacerebellar peduncle atrophy, hot cross bund sign, as we mentioned before, and metacerebellar peduncle hyperintensity, which are not uncommon findings in MSA that help us with the diagnosis. Also, changes in our sequencing, as we discussed before, and the WI hyperintensity in the putamen. Now, the definition of autonomic dysfunction changed slightly from the two criteria. And the idea is that it would be easier for clinicians to do this in practice and not requiring necessarily autonomic function testing. You can have a 3-day bladder diary and or post-void residual of more than 100 mLs and orthostatic hypotension, which is now defined as a systolic blood pressure reduction of more than 20 or more than 10 in diastolic, with a reduction of the heart rate of less than 0.5 beats per minute within 3 minutes of standing. And that should be divided by the change in the blood pressure. So how much is the heart rate increasing according to the drop in blood pressure? It should be less than 0.5. And you can have also the delayed neurogenic orthostatic hypotension that occurs 3 to 10 minutes after standing, which is a feature of clinically probable MSA. And the exclusion criteria includes some other features that might raise the suspicion for a different condition, including a substantial or persistent benefit with dopaminergic medications. We know that patients with MSA can have some degree of improvement with levodopa, but if that's persistent and dramatic, you might consider more of a Parkinson's disease diagnosis, unexplained anosmia or hyposmia, which is also more suggestive of Parkinson's disease, and fluctuating cognition or recurrent visual hallucinations, and dementia within 3 years of onset, all suggestive of dementia with Lewy bodies. The oculomotor difficulties, patients should not have the down gaze supranuclear palsy or slowing of vertical saccades that would suggest a diagnosis of PSP, and the brain MRI findings suggestive of an alternative diagnosis, of course, in the documentation of an alternative condition. Interestingly, the new diagnostic criteria or the 2022 criteria now defines biomarkers that they have limited availability and need validation. However, clinicians are encouraged to investigate. And I'm not going to discuss too much about biomarkers in MSA, but I have previously presented this last year. But the idea is that the biomarkers can help us in many different ways. It can be a diagnostic biomarker that would help us diagnose MSA early on. It can be a predictive biomarker that it might allow me to know which patient is at a risk for MSA or at risk for a specific symptom of MSA. It can be a biomarker that allows me to track progression and how fast or how slow these patients with MSA are going to progress, for example. Or it can be a biomarker that allows me to assess response to treatment. So, for example, depending on a new biomarker, I can know if someone is responding well to a treatment So they should continue this treatment or if I should change treatment. And in the case of the biomarkers, it is obviously a diagnostic criteria, so they talk more about the diagnostic biomarkers. The whole idea is that by having an earlier biomarker, we can catch these patients earlier on, even before the possible MSA, maybe the prodromal stage, so I can start treatment early on to avoid additional disability or additional symptoms. Among those possible biomarkers, there is neurofilament light chain, which I've discussed quite a lot last year, but the idea being that it's a marker of axonal injury, and because MSA progresses a little faster, you can have an elevation in this. This is not part of the diagnostic criteria, but just some examples of biomarkers that are out there. There is also the possibility of alpha-synuclein in the skin, and many other different biomarkers, including imaging biomarkers, which I'm not going to discuss here. But what's important to note about the new diagnostic criteria is that it encourages the use of biomarkers, even though there is not a specific one that is validated for the diagnosis of MSA yet. The MRI findings are supportive for some of the diagnosis, but none of the other biomarkers like neurofilament light chain or alpha-synuclein are part of this criteria. Now, let's look at a Mayo Clinic study in which they researched how accurate the new MSA criteria was for diagnosing MSA using the brains of patients that died. And it's important to say that this is a retrospective study. So they were looking back. These patients had died and they looked at their database to confirm, but they were not diagnosed with the new criteria. They were comparing the MSA criteria from 2008 and the new one from 2022. And they found that the clinically established MSA by the MDS criteria had a very high specificity of 99%, but very low sensitivity at 16%. And the clinically probable MSA improved sensitivity to 64% with a specificity of 74%. And by comparison, the older consensus in 2008 was more sensitive, up to 93% for probable MSA, but much less specific, ranging from 21 to 52%. So in summary, this study demonstrated that MDS criteria provided a robust diagnostic accuracy in this autopsy cohort. And for the patients and caregivers out there, this might be a little complicated, but the idea of this criteria is that the older criteria caught more cases, but maybe was less accurate. And overall, the new MDS criteria, especially the probable MSA category, gives the best balance between finding true cases of MSA and avoiding mistakes like diagnosing with MSA when they don't have MSA. So they do show that this criteria can help us identify MSA a little more reliably while reducing the chance of misdiagnosis. However, we still don't have any prospective validation of this new MDS criteria. So there are some strengths and limitations, obviously, to this MDS criteria. They're much better suited for early stage recognition, so they can provide a consistent framework that both clinicians and researchers can use. And in terms of limitation, we're still needing prospective clinical pathological studies validating the MDS criteria. Again, looking at these prior studies that are retrospective, it seems like the criteria has been doing quite well. And as I mentioned before, we don't have reliable biomarkers that can be universally applied. So these criteria are a step forward, but definitely not the final word in terms of diagnosis. So in conclusion, for this brief overview of the MDS criteria, it can enhance the diagnostic accuracy, which in turn will help us better enroll the right patients in clinical trials and advance future research. However, it is crucial for us to validate these criteria in prospective clinical pathological studies to confirm how well they perform in clinical practice. And finally, as research continues, we can anticipate growth in the number of reliable biomarkers, which hopefully will strengthen our ability to diagnose both MSA and prodromal MSA in real-world settings. With that, I would like to conclude this presentation, and I would be happy to take any additional questions or any suggestions. Just please feel free to reach out. Thank you so much for your attention.